Hello, everyone. Thank you all so much for joining this conversation with us during this time of crisis. I know that there are those of you coming from all over the world, from California to New York, from the UK all the way down to New Zealand. And it is just absolutely inspiring to be able to reach out to all of you here today. And I only wish that it was just under different circumstances. My name is Ron Lee. I am an inpatient medicine physician at Stanford. Like many of you joining us here today, my colleagues and I in the San Francisco Bay Area have been fighting COVID-19. And we are all just bracing for what is to come. I hope that you are all staying safe. We're going to get through this and we're going to do it together. The idea for this webinar was born out of a scramble among several of us to just learn as much as we can about how to best protect ourselves while we take care of patients with COVID-19. And then we quickly realized that there is just so much that we still don't know, so much we could learn, especially from the countries that have most successfully fought this pandemic. We know that as healthcare workers, especially those in the front lines, we are just at higher risk of getting infected. The data from China, from Italy, and from the rest of Europe and the US all show this. We have all heard of colleagues now falling ill, and some of them severely ill from COVID-19, while the rest just push on. And the thing is, if we get sick, we risk spreading the virus to our families, our friends, our communities, and we can also just no longer take care of our patients if we're sick. So that's why we want to learn everything possible that could help us protect ourselves so that we can best serve those around us. We have all looked to South Korea as one of the success stories in controlling this pandemic within their country, but also in how they have successfully protected their healthcare workers. I was lucky enough to connect with Dr. Chung from Seoul, South Korea, who has graciously offered to share his experiences as the director for the Center for Infection, Prevention, and Control for Samsung Medical Center, a tertiary care hospital. And they just have had extraordinary success in not only building workflows that work, but also just making sure that no one at their hospital gets sick. No staff member from their hospital gets sick from COVID-19. So we'll start with a presentation by Dr. Chung, followed by a question and answer session that I will moderate. Fortunately, we won't be able to get through all the questions, so I will do my best to highlight the most pressing and highest yield ones during this hour. I'd like to give special thanks to the deeplearning.ai team for making this possible, both by helping us reach out across the Pacific and also by providing this platform for this conversation. Now I have the pleasure to introduce Dr. Chung. As the Director of Infection Prevention and Control for Samsung Medical Center, he is one of the top experts in South Korea on hospital infection control for COVID-19. He is also the Chief of the Division of Infectious Diseases and Professor of Medicine at Sungkyunkwan University School of Medicine. He is also the Secretary General for the Asia Pacific Foundation for Infectious Diseases and also serves as the chair of the Scientific Committee for the Korean Society for Healthcare-Associated Infection Control and Prevention. Dr. Chung, we are honored to have you here with us. Thanks for your time.
Thank you for your kind introduction. Nice to meet all of you. My name is Ryeon Chung, and I'm very honored to have an opportunity to share our experiences in my hospital and also in South Korea. So let me share my slides first. Okay. So the outline of my talk today will be the situation of COVID-19 epidemic in South Korea, and also overview of national response in South Korea, and also I'll cover the response of the Samsung Medical Center at the hospital level. Let me start with a brief overview of COVID-19 situations in South Korea. As of yesterday, the number of confirmed cases is over 9,000, and the case fatality rate is 1.4%. As you can see in this map, the instance differs by the location. Daegu is the city showing the highest incidence density, and the province surrounding Daegu shows the second highest density. 72% are from a single city, Daegu, where big outbreaks occurred associated with worship or meetings of a particular religion, and 80% of cases occurred in clusters, mostly in chronic care facilities and healthcare institutions, and also some call centers of the company. And Seoul metropolitan area has a high population density, with accounting for 44% of total population in South Korea. So we have a very high concern on this area, although the instance of COVID is still low. As the outbreak in Daegu has been controlled thanks to participation of all citizens in social distancing and mask wearing, the number of new cases per day has become lower. However, the number of cases in Seoul metropolitan area has shown an increasing trend. Furthermore, the number of people diagnosed with COVID-19 is increasing among the people entering from overseas. South Korea, which suffered from the epidemic in several hospitals, that started from a single patient from the Middle East 5 years ago in 2015, has prepared a lot to cope with the crisis due to highly infectious disease. The government and healthcare institutions have been doing what should be done immediately as soon as the first imported COVID-19 patient was diagnosed on January 20th, and the people have followed these measures very well. In short, our response in Korea was to search all COVID-19 patients and trace all close contacts and quarantine all of them. Since it is expected that this pandemic will last for a long period, we are considering a new strategy to minimize the spread of infection in our daily lives while maintaining this strategy of search and isolate. Korea has a very heavy reliance on private sector providers of medical services, with approximately 90% of hospital beds being private. Therefore, active participation of private healthcare institutions was also essential. South Korea is one of the countries that have performed the most diagnostic tests for COVID-19. Currently, around 20,000 tests are carried out daily. Starting with 20 national labs in the beginning, 90 labs of hospitals or entrusted laboratories have been working on this together. After overcoming the MERS crisis in 2015, in accordance with the strengthened medical laws and regulations, there were a total of 1,027 negative pressure isolation beds nationwide. Although it is still insufficient in the surge situation, it was very helpful in dealing with the crisis. What about my hospital? The Samsung Medical Center is a tertiary care university affiliated hospital in Seoul. It is a very big hospital with a large number of patients receiving medical services every day, and also a large number of employees. A number of strategies have been implemented to prevent COVID-19 from entering and causing secondary infections in the hospital. We know that as COVID-19 starts to spread to the community, we face an increasing risk. The crisis response headquarters has been in operation since the first case in Korea was diagnosed. Our multiple strategies to prevent COVID-19 from entering the hospital were implemented at many locations. And the first step is screening at the hospital entrance. In order to prevent unrecognized COVID-19 patients from entering the hospital, body temperature is measured at the entrance and checked for history of traveling overseas and also cold symptoms. A strict policy of no mask, no entry has been implemented. The indicated person is asked to fill out a detailed screening questionnaire. The person who has a fever or respiratory symptoms, in particular who has a travel history overseas, is not allowed to enter the hospital and guided to visit the triage of the emergency department or a temporary COVID-19 screening clinic. Since the MERS crisis, all hospital walls are equipped with sliding doors to restrict visitor entry. Now, all visitors except one family member are banned from visiting the patient. Before the patients with reservation for medical service come to the hospital, we needed to make adjustment in their reservation based on their risk of exposure to COVID. So we send next text message with a screening questionnaire, which is linked to the web. If they have an increased risk of exposure, the schedule is postponed or telemedicine service is recommended. In Korea, DUR, Drug Utilization Review System, has been successfully utilized for the hospitals to be provided the information of history of traveling overseas. So hospitals are provided with immigration information through an automatically linked computerized system to know if patients have recently entered from the COVID-19 epidemic country. This computerized system also provides the information if they are close contacts of confirmed patients. This computerized network uses the DUR, which had already been operated, to prevent overlapping prescriptions of drugs between healthcare institutions. Pre-admission measures are implemented when patients requiring hospitalization come from areas where the outbreak occurred. They are screened for COVID-19 in the screening clinic before admission. A temporary COVID-19 clinic was established using portable negative pressure air conditioning equipment. Asymptomatic patients requiring hospitalization or healthcare workers coming from areas of serious epidemic area are tested here. Most suspected patients will visit emergency departments, so the role of triage is very important in the emergency department. The triage installed in a separate building away from the emergency room has been in operation 24 hours, 7 days since 2015 to screen patients with highly infectious disease. So all suspected patients are isolated in the negative pressure room in a separate facility outside the emergency department, and COVID-19 tests are carried out there. So we have a total of 11 negative pressure rooms in this facility. And there is an anteroom and also individual bathroom for each isolation room. And the portable X-ray machine for exclusive use in this facility is equipped. Inside this facility, we have also a right space for doing nasopharyngeal swab more safely. So the glass barrier here is located between the doctor's side and the patient side and the swab is conducted through a small rectangular opening. And the direction of the airflow is to pass from the doctor side to the patient side. With these facilities, in the emergency department alone, too many patients wanted to be tested for COVID-19. Therefore, outdoor temporary COVID-19 clinics were installed on the roof of the parking lot, away from the main buildings. So like this. Actually, this photo on the left was taken from the CCTV camera. So symptomatic patients who are blocked before visiting outpatient clinic or symptomatic healthcare workers are tested in this temporary clinic. Specimen collection can be done in more patients because you don't have to wait for the next patient's test until there is enough air ventilation like you do in an indoor clinic. Thus, all COVID tests are conducted only in specially designated clinics and are not permitted in regular outpatient clinics. This principle is in order to protect both healthcare workers and patients or visitors. The Samsung Medical Center has carried out the COVID-19 test since February 8th. We have been using one of 5 commercial kits, which were approved for emergency use by the Korea Ministry of Food and Drug Safety for diagnostic purposes. We started it in the mini lab in the communicable disease isolation unit that we have, but there was not enough space to perform a large number of tests. And so a temporary negative pressure lab was established, as you see on the right. The turnaround time in our lab is 4 to 7 hours. They do the test 8 times per day, so every 3 hours, same on weekends. And currently, maximum capacity is around 300 tests per day, but it will be increased to 500 soon. COVID-19 patients are cared in Communicable Disease Isolation Unit, CDIU, which is located near the emergency department and separate from other facilities. And there are 8 negative pressure isolation beds, including 2 ICU beds. We have another separate airborne isolation unit, which has 9 negative pressure isolation beds. Currently, pneumonia patients requiring hospitalization are being isolated here until COVID tests come out. In order to protect healthcare workers from COVID-19, especially in care of the COVID-19 patients, we have a dedicated core team for highly infectious disease. We organized and trained this team after MERS crisis in 2015. So this team comprises the specialists in infectious disease and pulmonary medicine, critical care, and cardiology, etc. And important thing is the residents and interns are excluded. And also the nurses, mostly from ICU, and radiographers is also included in this core team. So this core team is dedicated to care of the COVID-19 patients. And to support this team, the packed food is delivered to the isolation unit, and also temporary accommodation is provided to them, to those who want. They have 1 week's break with quarantine after 2 weeks of dedicated care, and they can return to care of non-infected patients after COVID test negative. So this photo was taken a few years ago. Core team has been trained regularly. And the core team has been conducted mock training and drills for various situations in preparation for care of patients with highly infectious disease. And Center for Infection Prevention and Control check whether the core team can perform everything properly as they had practiced through the training courses. And this photo was taken several days before we have started to care the first COVID-19 patients in my hospital. So thus, a core team has repeated training. One of the most important things to protect healthcare workers from the COVID-19 is wearing N95 adequately. So we have been educating the healthcare workers for adequate N95 wearing and support to choose the N95 product just right for their faces through the fitting test. In this COVID pandemic, there is an increasing demand for education of healthcare workers on proper donning and doffing of PPEs. So we have been continuing education of more and more healthcare workers who could be involved in care of the suspected patients. Our strategies to protect healthcare workers from COVID-19 include many things. So we are banning the hospital staffs visiting overseas or local areas where outbreaks occurs. And the principle is all events or meetings canceled. The campaign in the staff cafeteria will be told by me later. Importantly, all hospital staffs should report mandatorily their body temperature and presence or absence of respiratory symptoms twice a day using our messaging system. And the symptomatic staffs are tested after counseling with an ID specialist. And we are refraining from visiting public facilities even during off hours, and social distancing is encouraged. Okay, so this is the end of my slides. Okay, thank you for your attention.
Okay, well, thank you so much, Dr. Chung. This is extremely helpful, very informative, and just highly impressive and inspiring. Dr. Chung, did you want to keep your slides on, or did you want to share back your screen?
Yeah, I think we can go over to Q&A, and I will share more slides there.
Okay, sounds good. Well, so thank you again, and we definitely looked forward to learning more. And one thing that I wanted to just start by asking, it's a fairly high-level question, but I do think it's important, is many of us, especially here in the US, but probably other countries in the world, we look at this and we're just quite struck by how rigorous this approach is. It almost reflects, a certain level of fear and respect for the virus. When there are some, and for us, I think even not that long ago, there are many who say that the COVID-19 is not that different from influenza. And we certainly don't approach influenza with this level of fear and respect. So can you actually just talk more about why has your country taken this so seriously? Like, why are you investing so much resources in something that for a lot of people, it might not seem as that much more infectious than the flu?
Yeah, actually, we experienced another viral pandemic recently. That was 2009 influenza pandemic, H1N1. But we know that these two pandemics are totally different because the last influenza pandemic was just influenza virus. Even though that novel influenza virus was a mutant, some of our population had partly immunity against those virus. And also important thing was for influenza pandemic, we have vaccine. So we can make vaccine just within 3 to 4 months. So we can start to provide vaccination to the people. And also we have a very effective antiviral agent against influenza. Compared to this influenza, novel influenza pandemic, this COVID-19 pandemic is the first pandemic caused by coronavirus. So all population on Earth has no immunity against this virus. So anyone can be infected by this virus. And also we don't have any vaccine. Even though we hear that the first or the second vaccine trial has been started at various locations, but we have to wait at least 1 or 1.5 years, although it is successful. And we don't have any effective antiviral agents for this COVID-19 at the moment. And we, from the experience of the past 2 months, we know that this COVID-19 is more fatal than any other previous influenza pandemic. So the case fatality rate is like above 1%. We hear that very high case fatality is observed in high risk groups, including the old aged and also the patients have with underlying diseases. And the R lot of this SARS coronavirus 2 is very high at this point. So it is easily transmitted between each other. So I think this COVID-19 pandemic is can be very dangerous. So many experts saying that this kind of pandemic came to us just in 100 years. So after the previous 1919 influenza pandemic. So I think this is very serious at this point.
Thank you. I think that is really important to hear, especially since I think there are many different versions, I think, of vigilance, I would say, and respect and fear of this virus, just because I think there are many different opinions and different types of messaging. And I think that you do see a difference in the level of response depending on how serious you take this pandemic. And something that also struck me was that it sounds like what you're saying is one reason why this is so dangerous is that this is something that the human race has never seen before. So there's no herd immunity. There's no vaccine, at least in the near future. Antiviral trials are happening, but we don't really know how those are going to work out. So in a sense, even if the case fatality rate is, it's not extremely high, I mean, it's higher than the flu, but it's in the single digits, there isn't really much of a ceiling in terms of how many people can get infected, because it could actually spread to everybody, given that no one is really immune to it. Is that a fair way of summarizing what you're saying?
Yeah, that's a good summary.
Mm-hmm. So the other thing I wanted to ask you then is specifically as the Director of Infection Prevention and Control for a hospital, how do you think about the hospital then as an area where outbreaks can occur and the specific risk to healthcare workers? What's so special about a hospital that makes you so much more extra careful?
Yeah, I agree on that. So the hospital is one of the most dangerous areas during this pandemic. I think we have to be very cautious about the infection of healthcare workers and also the outbreaks which can occur in the high-risk patients. So that is the reason why the Samsung Medical Center has made many efforts to block transmission inside the hospital. Yeah.
And are you, like, how do you think about the risk of patient to healthcare worker transmission versus healthcare worker to healthcare worker transmission versus healthcare worker to community transmission? Are you equally worried about all three, or more worried about one over the other?
Yeah, actually, the risk of transmission of such a kind between each other will be very high. But from the experience of during the past 2 months in South Korea, we have seen many situations that there had been no transmission, although the COVID-19 patient was recognized at the late period. So even though there had been many exposure events inside the hospital, in case that the COVID-19 patients wearing masks on every occasions, and also the healthcare workers wearing masks, then the secondary infection does not occur. So the wearing the mask inside the hospital in both the patients and also healthcare workers is very important to avoid the possible secondary infection or transmission.
That's interesting, because you do emphasize this practice of wearing masks inside the hospital, regardless of whether or not you have symptoms. So can you explain that more?
Actually, the purpose of wearing mask will be in both, like to protect a healthcare worker or patient from being infected. And another big important reason why we have to wear the mask will be in case that I'm an infected person, we can prevent infecting other persons by wearing a mask. So I think the second reason is more important in terms of the blocking transmission of COVID-19.
And you are referring to not N95 masks, but regular surgical masks?
Yeah, actually, just regular surgical mask is recommended for all hospital staffs in every situation. But N95 respirator will be required in the special care, such as the procedures that can generate aerosol, or some aerosol generating situations, such as severe coughing patients. In those situations, N95 will be the minimum protection. And I can show the slides, the standards, the precautions in my hospital. So let me share those ones. So can you see the slide now? Do you see?
Yes, I do.
Yeah, okay. Yeah. So in my hospital, all hospital staffs are required to wear surgical mask in every location. And when we care the patients with airborne infection, N95 is required. And for aerosol generating procedures, we need 4 kinds of PPEs. So N95 and the face shield or goggle or shield mask, and thirdly, the gloves, and the last part is the surgical gown. And so the same 4 kinds of PPE is recommended for staffs working on the gate control and the triage, and the healthcare workers carrying the unexplained pneumonia. But for healthcare workers carrying COVID-19 patients, full protective PPEs, including PEPPER, the powered air purifying respirator, is recommended. Yep.
So can I ask then, if you go back to your previous slide, you talk about wearing N95 masks and surgical gowns for procedures. So you're saying that you recommend wearing N95s for doing procedures regardless of whether or not you know the patient has COVID-19.
Right. So even though we don't know about their presence of COVID-19, we recommend all these strict PPEs for the healthcare workers involved in those kinds of care.
And can you explain why?
Because we are trying to find every COVID-19 patients using multiple strategies, but it cannot be 100% because the COVID-19 has been already spreading in the community, and there are so many infected persons which have little symptoms. So we cannot recognize 100% of suspected cases. That's the reason why we apply the strict precautions for all patients' care.
And are you saying that you would also classify someone with a severe cough as someone who potentially would be generating aerosol?
Yes, I think so. So for example, when carrying the outpatients clinic, we usually start with just a surgical mask. But when the patient who has severe cough comes in, I switch it to N95 before carrying those patients because I can be infected with just a surgical mask. Actually, many experiences in previous researches comparing the efficacy of prevention between N95 and surgical mask in terms of the influenza prevention. There was no significant differences if we wear those kinds of masks or respirator properly. So proper wearing is very important in both N95 and surgical mask. But theoretically, N95 will provide more protection against the airborne infection.
And are you aware of any data then specifically for COVID-19 and the potential risk of transmission with a surgical?
I think there has been no report on comparing the efficacy of two mask or respirators in terms of COVID-19 prevention.
But it sounds like you are using the N95 masks anyway, just out of extreme precaution because of how dangerous you think this virus is.
Yeah. But for general care, most situations in hospital, surgical mask, proper wearing of surgical mask is very effective to prevent COVID-19. But to make prevention more perfect, N95 is necessary in some situations.
One thing that we are starting to learn here is once the viral particles become aerosolized, let's say from a nebulizer treatment or intubation, those particles, there are some data that shows that the particles hang around in the air for several hours. Is that something that you have seen as well and are incorporating into your PPE protocols?
Actually, we believe that this COVID-19 is transmitted through droplet transmission. So airborne transmission through very small aerosol particles is a very rare situation. So it's possible, I believe, but it is a rare situation. So we need to focus on the droplet precaution using the mask or respirator. But we have to find out in which situation we need to imply more strict PPEs, including N95. So in the clinical department need to consider in our medical services, which services will be at high risk of airborne infection. So in those procedures, we have to provide N95, I think.
And you showed us your entire set of PPE for COVID positive patients, which includes not just N95s, but full body suits, the PAPRs. So can you explain the rationale for having a full body suit rather than just a mask with a gown?
Yeah, when we care the critically ill COVID-19 patients, the very dangerous procedure can be performed inside the rooms, just like this. This was photo when we cared a very serious patient with COVID-19 in February. So this is the photo showing the physicians doing the tracheostomy at emergency. So in those situations, the healthcare workers can be at risk of contaminating their body parts. So full body protection is also important in this situation, because we know when the droplet contaminate our body part and our hand touch that, and then with contaminated hand, if we touch on our face, we can be infected. So I think that's another way of transmission of COVID-19. So we have to protect against those kinds of transmission when caring the serious patients. But if we just go in and ask something to the patient and go out, and then we don't need such kind of protection. We just wear N95 and glove and surgical gown and enter the patient and conversation for a short period and can go out. So it depends on the situation of patient care.
Mm-hmm. So what would you recommend then specifically, say, for a patient who is on the wards, who's coughing? You're not necessarily doing a high-risk procedure, but you are close to them, you're putting into a nasal cannula, for example, maybe you're putting a mask on them to provide oxygen. So you're fairly close to the patient, they're coughing in your area. What types of PPE would you recommend in those situations?
Actually, in my hospital, we are recommending the 4 kinds of PPEs, including the N95 and the face shield. So I think 2 is important. So the N95 and also face shield covering the eye area, and also gloves. 3 will be mostly important. And the last part is the surgical gown or any disposable gown to cover the anterior body surface. So in the bronchoscopy and also endoscopy rooms, they are already wearing those kinds of PPEs in my hospital. So every time.
Do you have any specific thoughts on the potential need for covering your hair and your shoes?
I think we can cover the hair part and also the shoes, but it is the least important thing, I think.
Mm-hmm.
So in case of seriously ill COVID-19 patients, we cover hair and also the shoes. I think for women, the covering hair is more important because it can be contaminated easily.
Because you're saying the droplets could potentially land on your hair, and then if you touch, you could actually transmit it that way.
Yes, right.
So if you have long hair, so the more exposed surface area, it sounds like that would be more important than maybe someone with my hair, which is pretty short and much less surface area. So that makes a lot of sense. So I wanted to go back then to the idea of this primarily being a droplet, or the transmission primarily being droplet, because I think there's a lot of confusion now, especially in countries with a limited number of N95 masks. We are at a point where sometimes we only have a surgical mask and we're told to go into a COVID positive room with a surgical mask. So can you just describe maybe, I mean, based on the data you do have and your experience, what level of risk is that? Do you think that's more or less enough, or do you feel like that's something that typically is not going to be adequate in protecting healthcare workers?
Yeah, actually, the problem is the shortage of the PPEs in many areas. My hospital has also the issue of the running out of the surgical mask, and so we are checking the stockpiles of every PPE every day to see whether we have enough amounts to maintaining the PPE policy. So if we don't have any stockpile for the next few days, we should change our policy about PPEs. So just like that you mentioned, N95 could not be provided to the high-risk procedure. So I think it is important that we understand that N95 respirator is better than surgical mask in terms of protection, but surgical mask is also very effective. So we should understand that, and the proper wearing of surgical mask and hand hygiene can be very effective in prevention of COVID-19. But if we have enough stockpile of N95, we need to provide N95 to healthcare workers involved in high risk.
Mm-hmm. And you mentioned the proper wearing of surgical masks. What are the most common mistakes that people make when they wear surgical masks?
Actually, healthcare workers usually follow the the wearing principle, but many patients or general public do not cover their nose, just covering their mouth. So they have to learn what is the proper way of wearing of surgical mask. And also most products of surgical mask has the nasal clip to help the fitting in our face. So we have to just fit the surgical mask in our face. And also we should not touch the anterior surface of surgical mask with our hands, because our hands can be contaminated by some viruses. So surgical mask is very a simple one to protect, but the proper way is very important to provide effective prevention.
That makes sense. So this is really, really helpful. Again, thank you so much. And many of us, I know in different countries around the world are facing PPE shortages. And I think, you know, the worse the shortages, the more creative we'd have to be in terms of providing at least the best possible protection we can provide for ourselves. And it is reassuring to hear from you that surgical masks, as long as they're being worn appropriately, actually does quite a bit. It sounds like it is not going to be as effective as N95s, but it is certainly better than nothing, and it's fairly good. So I think that's reassuring for a lot of people to hear. And then the last thing is, you did mention that patients do have to wear masks in rooms. Is that something that you do mandate in your hospital?
Actually, for the patients, we do not recommend wearing a mask inside their rooms, even they are COVID-19 patients. Actually, COVID-19 patients will have respiratory distress in many cases, so they cannot wear the mask, and also they don't need to wear inside the room. But in case that we need to transport the patient outside the isolation unit, they need to be covered by a mask. But in case that they have any respiratory distress that they cannot wear the mask, we need a negative pressure isolation transport equipment when transporting the COVID-19 patients. So like this here.
I see. So this is if the patient is on some oxygen device and can't actually wear a mask. So this is how you would
yeah. So for COVID-19 patients, when we need to transport those patients to other location, as you can see in the photo on the right, we can transport the patient using the negative pressure equipment, but sometimes we need to transport without it, like the photo on the left here. So in this case of transport without special equipment, N95 cannot be adequate for such a transport because N95 fitting is not guaranteed. If the healthcare worker is moving their head a lot like this to help the patients move during the transport. So I recommend wearing a full protective PPE, including the pepper, when we try to transport the COVID-19 patient without this equipment.
You're saying that even if a patient is wearing a mask, you're still requiring the providers to wear full PPE because you're afraid that the mask.
Actually, we don't know which event will occur during transport. Even though when we started to transport, the patient was in calm condition with wearing mask, but the patient can have a sudden respiratory distress or the coughing, vomiting. So in those cases, the healthcare workers can be exposed with simple PPE. So when trying to transport COVID-19 patients, we need to consider the full protection. Actually, if we use this the transport equipment, the full protection might not be important.
I also remember you mentioning that you've organized your units to minimize the distance needed to be traveled by COVID-19 patients, correct? As in you have your isolation units fairly close to your emergency department.
Right.
And it sounds like your isolation rooms are actually all in one unit so that providers who take care of COVID-19 patients do not have to traverse the hospital as much. They would actually stay in one area of the hospital the entire time they're working.
Yes, right.
And they are donning and doffing every time they enter an isolation room, is that right?
Yes.
Okay, so it's not like they're staying in one shared unit with PPE the entire time, because we have seen that in some other countries.
Yes, right.
Okay. You did also mention that you deliver food to those units. Does that mean that the providers do not actually leave those units the entire day they're working there?
It's not mandatory. So we recommend, as they can do, we prefer the healthcare workers, the core team, to not leave the hospital, but it is not mandatory recommendation.
I also wanted to ask you about how you're testing your staff. You mentioned that you have the staff report their symptoms, self-report their symptoms and their body temperature every day. What is your approach to testing staff? What is your threshold for testing and retesting? How do you think about that workflow?
Yeah, actually, this is our policy for testing healthcare workers. So the indications are like this. So we test the healthcare workers returning from overseas, now every country abroad, or local areas showing high rate of COVID-19, so like Daegu in South Korea. And also we test healthcare workers with family members from overseas or blah, blah, the same indication. And also we test healthcare workers with symptoms, fever or respiratory symptoms. And we also test healthcare workers who are notified to be a close contact of a confirmed case.
And that's assuming that they were not wearing PPE during that contact?
Yes, right.
Okay. So if a healthcare worker is regularly caring for COVID patients, but with full PPE, do you have a policy of testing them?
So you mean in case the healthcare workers are exposed to the COVID-19 patients with adequate wearing PPEs? In that case, we don't test the healthcare workers. But as I already mentioned, when the core team finished their duty over 2 weeks for dedicated COVID-19 patient care. We tested those core teams before returning to general patients care.
Right. I mean, a theme that I hear from all of this is this theme of isolation, in the sense that you are doing everything you can to isolate everything that has to do with COVID-19, both geographically and both in terms of personnel, so that you can essentially quarantine off any potential transmission from where the COVID-19 is in your hospital to elsewhere in your hospital.
Mm-hmm.
Can you talk a bit about, I mean, has this been successful so far?
Actually, we mentioned that all COVID-19 patients are isolated using the negative pressure facility nationwide. But I mentioned that the maximum capacity of the isolation facility is about 1,000 nationwide. And we have active cases about 6,000 now. So we cannot isolate all those infected persons. So the Korean government is doing that the mild cases can be just quarantined at their homes, and more preferably the training centers of the government or the training centers of some big companies are being utilized as the quarantine area of the mild COVID-19 patients. And many volunteer doctors and nurses from many healthcare institutions are going there, the training centers with confirmed mild cases, and they are consulting their symptoms and considering when they should be transferred to a hospital, so like that.
This is such a massive undertaking for your team. Such a large hospital. You mentioned you had 9,000 staff members.
Yeah.
You had a huge change to their normal workflow. How are you able to engage all of them and have them do all this in such a regimented way?
Yeah, actually, we have a lot of healthcare workers and so many patients inside the hospital. And in Korea, there are a few hospitals with very similar situations, and we have a concern about the increasing risk inside the hospital, risk of infection inside the hospital. So that is the reason why we have been implementing so strict policies to prevent the transmission. Yeah.
It sounds like just a culture of seriousness that everyone attributes to this.
Yeah, actually, another important things in prevention of healthcare workers from infected by COVID-19 is occurring at off day of hours, because they can be infected in the community. So we are encouraging just following the general principles of social distancing to 9,000 healthcare workers. But I'm not sure the principle can be followed by all healthcare workers 100%. And I'd like to show some ways of preventing transmission between the healthcare workers. So as you can see here in the photo on the right, sorry, let me find. Yeah. So for the safety of our healthcare workers, we have been finding and doing additional things we can do. So for example, the glass, the acrylic barriers were installed to protect the workers at the reception desk of the administration, so like here. So it can block the droplet transmission between the healthcare worker and visitors. So that has been installed recently in my hospital. And every hospital has a big call center who deal with the patient's reservation and changing of those schedules. And this call center is at high risk of transmission between each other because for clear conversation, the workers here usually prefer the wearing of their masks and the distance is so close. So we made a change. So the employees working here should wear a mask at any time, and the seats were rearranged so they were seated one by one, just like here. So to reduce the risk of transmission between these people. And also when eating, especially in the staff cafeteria, they have to take off the mask for eating, which may spread the COVID-19 in the staff cafeteria. And they want to conversate each other. So I think the cafeteria in the hospital is a hot place with high risk of transmission between each other. So the hospital have started the campaign silence during the dining and sit side by side without facing each other. So in this cafeteria of in one of buildings of my hospital, there is no chair at this side. So nobody can sit facing these people. So we have been doing this campaign.
It must be very quiet in the cafeteria, huh?
Yeah.
Well, this is, again, very, very helpful. And we only have a couple of minutes left. I'd like to ask one more quick question and then also just have you maybe help us summarize, just give us some advice, really, that we could take forward. The last question I have is, you do make a very important point. I mean, even now, as you have thousands of cases in your country, it seems like you are doing everything you can to prevent transmission, which is a different approach than, say, we already have so many cases, why don't we just let it spread and then we'll just so-called flatten the curve and slow it down. Do you think that's, so given that at least in the United States, we have different states with different levels of infection. So in New York, unfortunately, they've been hit very hard. California, we've been hit hard as well, though not as much as New York. And then we also have other states actually that are starting to see cases, but not nearly as, the numbers aren't nearly as high. So from your perspective, what would be the best approach to really solving this problem for a place like the US, where you have all these pockets of infections, they haven't quite exploded in the way that some areas have? Is there a chance to still contain this infection?
There's it's a very difficult question actually. So because everyone knows that this COVID-19 pandemic will last for a long period, like 1 year, and at any time, many persons will be infected. But the important experience that we shared is the situation in Wuhan, China, at the beginning of this pandemic, and also the situation in Daegu city in South Korea. And also we have been seeing very serious situations in Italy and other European countries. That's a dangerous situation occurred when the transmission was so active without any kinds of the efforts to prevent transmission in the community. So those numbers of increasing infected persons surpassed the surge capacity of the city, of the country, and so many the fatality has been caused. So although we are facing the pandemic lasting for a long period, and we cannot block this transmission by vaccine, we need to slow down the transmission. in every community and in the city and at the country level. That is the way we can reduce the number of the fatality.
And it sounds like these measures of social distancing, of wearing masks in public,
right,
like that has really played a huge role in your country.
Yeah.
Mm-hmm.
And also, although the community starts to loosen the social distancing, because we also need to do work, and also we need to be involved in economy, the production like that. But the last place that we have to address social distancing will be healthcare institutions and also the chronic care facility. So we are working at the place where the most strict policies should be applied.
Well, I think that's a good place to end. And what I'm taking from this is that this is very hard. You know, there's no real answer at this point, and seems like the solutions will have to be adapted, of course, to wherever you are. But at the same time, I think you give us a lot of hope, because this is a situation that your country has done a very good job addressing, and the measures that you've implemented are doable, I think, in many places. I think there is a real equipment shortage. I think there are places that just will not have enough full body suits, will not have enough N95 masks. And I think, you know, we will have to adapt as healthcare workers. At the same time, I think what you're describing here are measures that may not even require as much equipment, but it's more of maybe a mentality, a shared mentality among your people, which is that this is serious, this could get a lot worse, this is nothing like we've ever seen before. We need to come together as a country to do this. And also this maybe a concern specifically for the healthcare workforce and the healthcare workers in healthcare facilities, is that being such a high risk area that almost everything has to be done to make sure that that area is as safe as possible. And I think that that's something that we will have to work on. And, you know, we have our constraints, we have our PPE shortages, but I also think that that's a problem that's solvable. We know how to make masks, we know how to make all this equipment. I think it's part technology, but also part political will. And I think that's something that hopefully we as healthcare workers can come together and figure out how to solve together. So with that, thank you again, Dr. Chung. We really, really do appreciate it. We look to you for guidance, also just again for hope as we fight this together. Thank you again for the deeplearning.ai team for really facilitating this. We really do hope to continue this conversation. So for those of you listening, if you have any ideas or suggestions, please email us. And with that, we will end this session. Good luck out there, stay safe, take care.
Okay, thank you very much.
Bye.
I hope we can overcome this pandemic well.
We will.
Okay. Bye-bye.
Bye.